Thank you. All righty. Okay, so here are the training objectives. And these objectives also serve as an agenda for today's training in the order that we're going to talk about things. So first, we're going to gain an understanding of the NC Detect data and its limitations. I have a lot of information to present to you about the data and how to use it. So just bear with me as I go through that, but it's really important to give you context to the data that will be presented. And we're going to learn how to navigate and use the sexual assault emergency room visit dashboard that NCCASA has created. I'm going to, click through my screen and show you what it looks like, how to get to it, and how to use it. Then we'll have a large group discussion to brainstorm ways to use the data that will help us improve services for survivors and advocate for change. We really want to hear from you all about plans for how to use this information that will emerge from the dashboard. And then at the same time, we're going to explore how you all as community-based organizations may want to use the data, again, uplifting how you all are using it, because in full transparency, we're still tweaking. Well, DPH is still tweaking the data. And in our resources we're providing to you can also be adjusted, and we want to make it as relevant for you. So we want to hear again from how you may want to then take this information and use it. And I'll also share a visual for you all as an example of ways to present this information. All righty. So let's get started with the NC Detect data. And so before we explore the actual dashboard, before we get into the fun stuff, which what I think is fun, looking at numbers, I want to tell you about the information, the data that the dashboard is built upon, and it's the NC Detect data. And NC Detect stands for the North Carolina Disease Event Tracking and Epidemiologic Collection Tool. So very nice, healthy acronym that fits into what it does. It's our state's real-time emergency department surveillance system, and that helps us to monitor public health trends and also to better prepare for emergencies for service providers, for health systems, for organizations who help people across the state. And NC Detect was created by the North Carolina Division of Public Health in 2004, so it's been around a while. In collaboration with a couple departments at UNC, the Carolina Center for Health Informatics, and the UNC Department of Emergency Medicine. And so they maintain this system that collects information from various sources, including emergency departments across the state, emergency medical services or EMS services, from the North Carolina Poison Control, and I think even recently from urgent care centers across the state. So this information is being collected ongoing and updated in the system. And for the purposes of our training today, we're focusing on the emergency department visit data, that emergency department visits for sexual violence data. But there are key points to remember for the NC Detect data when you're using it. And again, as I go through these key points, keep them in the back of your head because it provides context to what the findings mean. And also, if there are any questions or if you need clarification, again, raise your hand or add in the chat, and I'll hopefully be able to answer them. But the data, the NC Detect data is what is used for the dashboards, and the dashboard that NCCASA created uses what's called visit-based data. So these are not counts of individuals, not counts of patients, but they're counts of the number of visits to the emergency department. So if one person comes to the ER multiple times, each visit is counted separately. And I'm going to be using ED, emergency department, ER, emergency room interchangeably, but I mean the same thing, the emergency care services at a hospital usually. So again, the dashboard is based on a number of visits, not necessarily a number of people who access the emergency room for sexual violence. Second, The visits that we'll be looking at in a dashboard are identified using a pilot definition of sexual violence. And this is really important because this definition is still being tested for accuracy, is still being sort of tweaked to see how accurate it can be and how it can be improved. But the definition includes data from various elements like patient demographics that are reported on when folks go to see the doctor at the hospital. This from chief complaints for, why they are presenting at the hospital. It comes from triage notes and also diagnostic codes. So the diagnostic billing codes for sexual abuse that's been confirmed or suspected, or codes for rape, those are captured. And then keywords in the triage notes and things like that are related behaviors to sexual violence. So even social determinants of sexual violence, such as experiencing sexual harassment at work, if that is in your triage notes or in your care notes, that might get picked up as a visit for sexual violence in the data, in the dashboard. And also keywords like SANE, the sexual assault nurse examiner, SA for sexual assault, or SAFE, sexual assault forensic exam. So those kind of keywords are what's being picked up in this data. So it's important to know that, again, this definition is being tested in real time and assessed for accuracy. And that's kind of part of why we want to do the large group discussion later, to hear from you all about sort of your uses of the data, and that would help DPH tweak it. So again, it may not capture all relevant visits to the ER for sexual violence. There might be some that are missing, and can also include some visits that necessarily aren't directly tied to sexual violence if it had a keyword in the visit narrative related to sexual assault or violence. So the keyword matching can miss some visits, or it can include generic ones that aren't actually related to sexual violence. So again, these numbers aren't perfect, but these are something to just keep in mind. And then also, because sexual violence is often underreported because not all survivors go to seek medical care, the data is almost certainly an underreport or an underestimate of the scope of the issue in your service agency or service service provider county. So just keep those in mind, and those concepts in mind, and examine the data with a critical lens, and always remember that the numbers are likely underreported. And we'll practice using that critical lens to examine the data when we get into the dashboard. Another key point to remember is that this dashboard is organized by NCCASA member organizations and their service areas. So meaning the county or the counties in which you work. It's not organized by patient residents, but by the county in which the visit took place. And so you can match to see where your member organization is. You'll see the county that you serve, and then the information for that the county where the visit took place. But you know that even if you're not a resident of the county, most people who experience an event do tend to visit the emergency room that's closest to them, where they live or where they work or where the event occurred. So even though it's not perfect, this method still offers like a meaningful way to look at the local trends and to understand where the support and services are needed in your provision area, which is important for helping to tailor things like advocacy services and other community outreach strategies. And then the last point to remember about this data is that it's only for internal use, and we're limiting access to the dashboards to only NCCASA member organizations through the coalition manager. And this is because the data is very sensitive, and we're getting, especially if you filter by county or service area or organization, you're looking at very specific areas, and with limited numbers, right? And we don't want anything to anybody's privacy to be harmed because of information getting out like that. And also because they're still tweaking the definition of sexual violence, it's not perfect data right now, which no data is ever perfect, but it's not they're still testing it. So we're only providing it for NCCASA member organizations who are using it in intentional ways and won't use it for harm. Like I mentioned in, I guess, the introductions, people can twist and turn any data, any numbers to fit their narrative, right? And to make or to portray a certain message about a certain group of people. And so we don't want access to this information for folks who might use the data in a harmful way. We want it for people who will use the information to advocate for change and who are participating in this training now to learn how to use the data in ethical ways, in ways that reduce harm. And so when you're sharing information gathered by the dashboard, you know, in your materials and your advocacy, just mention that these are trends, right? And use it to start conversations, and also mention that it's pilot data and it's really used to help inform your strategies and not really to report definitive numbers as 40 people accessed the emergency room in 2023, right? We don't want to say definitive numbers, you can show trends over time. So if you have any inquiries about the actual NC Detect data, where the dashboard data comes from, please reach out to Katie McDaniel at DHHS, and her contact information is below here. And I'll also, after the training, share some resources, and that will also be on there, so you don't have to jot it down now. But are there any questions? I'm going to stop here. Are there any questions about the NC Detect data before we move on to what the dashboard looks like? Okay. So I hope that was clear. And remember, again, this data is a powerful tool to help inform your services, your programs, and also to enhance the services for providers, for survivors. But the data must be handled responsibly, ethically, and we'll again talk about some of these issues later on in the training. And one thing I will also mention is that we are piloting we're seeking feedback rather on the dashboard itself that we're about to review now, and the visuals that I'll also present later. And if there's something that seems off, or if you see gaps, or there's information that's missing, please let us know. We want this dashboard to be as beneficial to you all, as useful to you all. So any feedback is welcome, and we have a feedback form that's associated with the actual dashboard and with the one-pager visual that I'll share later, that you can use to provide feedback on. I'll share the link to that at the end of the training. And I'm going to keep reminding you that this is a work in progress, and we want to make it as useful to you all. So please share your feedback. Any feedback that you do have, and that form will be open over time. So if you're not using the dashboards now, or you use them in a few months from now, that will be available for you. And also just reach out. You can use that to reach out for any questions. All righty. So moving on, since I don't see any questions, like I mentioned, the dashboard was created by NCCASA for your use, using all the NC Detect data from emergency rooms across the state. And so now I'm going to navigate to it so that you all can see how to access it. Then we'll talk about it. There we go. Okay. So you can all still see my screen, right? Great. So now I'm going to the Coalition Manager, which is NCCASA's Coalition Manager. This has all the resources that are accessible to you. This is how you signed up for this training. Hopefully you all are familiar with this, but if not, you can get to know it intimately. If you go to the Resource Manager side here on the left panel, there's a dashboard option. Click that. The dashboard, the data dashboard, is under the resource sheet and booklet tab, so you can click on that. And it is right here called Data Dashboard Sexual Assault Emergency Room Visits in North Carolina. You can also search for it using the resource search button on the left side, and just type data, and it will come up. here, and this is what it looks like. And you'll have to download it by clicking. And it will emerge. And it's an Excel spreadsheet. So you have to have Excel. And this is what it looks like. I'm just going to zoom out just so you can see it all together, and then I'll zoom in and we'll go through in each individual part. So this is what it looks like. It's a very simple tool, one page. On the first tab, it's in English, and on the second tab, it is in Spanish. So I'm going to zoom back in.
Hey, Bianca, we actually can't see the Excel sheet.
Oh, okay. Thank you. Let me. Reshare. Okay, what about now?
Yes.
Okay, great. So I will share again what I just said. This is what the data dashboard looks like. I will, after you download it, it's an Excel spreadsheet, and I'm going to zoom out so you can see what it looks like as a whole. It's just one page of information. It's a very simple tool to use. On the first tab, it's in English, and on the second tab, it is in Spanish. So I'm going to zoom back in so we can see the different components. So the top part just gives you instructions on how to use it and access it. So we get on row 2 to the fun stuff. This is the sexual assault emergency room visits in North Carolina from the years 2019 to 2023. In row 3 is where you will filter for your agency. Again, this information is organized by agency, and then also service area. So let's find one, safe space. I know that they work in Franklin County, so all this data is for Franklin County. So again, you have to filter to find your organization, and all member organizations should be listed here. I'm actually seeing, and even at first glance, that there are some missing. Like, I don't see Post Center up here. So this needs to be updated. When you are going through it on your own, again, if there's any information that's missing, particularly your agency, please let us know using that feedback form, or you can contact prevention@nccasa.org, and we'll get that information updated for you.
Yeah, Bianca, I just
yes, go
want to
ahead.
add and pose one of our newer agencies, newer members. They joined since they got the RPE contract, so there are going to be a few agencies, people on this call whose agency might not be represented yet. But yeah, we can update it.
Thanks for that update, Omar. And so we will get that updated, but please let us know if you're not seeing your name so that we know to update it. And okay, I'm seeing Vivian in the chat. Could you show what we click on to get this to one more time?
Sorry, I just couldn't remember on the dashboard what you clicked.
On the actual dashboard or on the coalition?
Yeah, on the dashboard. Yeah.
Okay. It's in row 3.
No, sorry, on the coalition.
Got it. Okay.
Page.
No problem. That is no
sorry.
No problem. So I'm back on, can y'all see this?
Mm-hmm.
Okay, I'm back on a coalition manager. I signed in, and if you go to the left side, click on dashboard here, and it's under resource sheet and booklet.
Okay.
And it is called the Data Dashboard Sexual Assault Emergency Room Visits in North Carolina. You just have to click on it to download it. Or you can go to, no problem, go to the search on the right or the left and type in data or something. Yep, and then so you download it to your computer. Now let's go back. Y'all can, sorry, I'm checking. Y'all can see this, right? The Excel spreadsheet.
Yes.
Thank you. Okay. So after you download it, again, the first tab is on English, and then to filter by your organization, you'll just click in this filtering option here in row 3. But for purposes of today and walking through the findings and how to use the dashboard, I'm just going to use North Carolina as a whole. And this is good for comparing your service area to North Carolina as a state. So that's why this data is available. And again, we will add those that are missing, those new organizations. So it tells you a couple of things I want to point out before we get into the information that it spits out, is that this information is, again, it tells you who is organized by agency, and it tells you who your agency service area is by county. But this information is for the number of emergency room visits between the years 2019 and 2023. And that's an important note, because these numbers can be so low. We want to see sort of trends over time, and these are the last years of data that we have so far, and it combines 5 years of data between 2019, the full year, all the way through the full year of 2023. So 5 years of data, and it combines it into a single time period, which we think offers a clearer picture of more recent patterns of people who are most likely to seek care after emergency care after sexual violence. And while we can't track the year by year changes, this sort of combined view helps us identify which populations are most impacted and where support might be needed the most, because you can see these general trends. The current data goes up to the end of 2023, but I do believe, and Sarah, please correct me, that the NCCASA data from 2024 is coming out this summer. Or we finalize this summer, and then we will be able to update the data dashboard. Do I have that right? Sarah's on. I did single Sarah out, so I'll find out for sure. But I do believe that the updated data, so for all of 2024, will be available this summer, and then the data dashboards will be updated for you. But we do have information for the last 5-year period for the most part, and you can again see those general trends. Okay. So the dashboard creates your information for your service area in 4 different data points. And the first data point is the total number of emergency department visits for sexual violence, keeping in mind that definition I described about where they're getting visits about sexual violence from the diagnostic codes, from the written triage notes and things like that. It's the count of the number of emergency department visits, right? Not people, but visits for sexual violence in your service area. It also provides the visits by gender identity, the visits by age group, and lastly, the visits by race and ethnicity group. So again, these are ED visits, not individual patients, but it does tell you about who is seeking care at emergency rooms specifically for sexual violence. So let's go through the data here, and I'll describe the findings, the trends of each graph, and explain sort of what the trends mean. And I want you to pay attention to, I guess, how I'm speaking about it, because this is how language that you could use to mimic when you talk about your own service area and the findings that you have. So across the state, I'm looking at this first data point and starting in row 6. Between 2019 and 2023, there were a little over 18,500 emergency visits to the emergency room for sexual violence across the state of North Carolina. So what does that tell us? It tells us that sexual violence survivors are seeking help from emergency rooms in North Carolina, right? The number isn't 0. And 18,500 is sort of up in the air. You don't know if that's a lot or a little, but that allows you, if you have it at a state level, allows you to see in your service area the comparison, seeing what chunk of that comes from your service area. And yes, Sarah, the question I had for you was the 2024 data, NCCASA data is being updated, I believe, at the end of the summer. By the end of the summer, is that correct?
Yeah,
Yeah, thanks for posing that. Sorry, I'm splitting my focus here. I'm not totally sure of when exactly it's going to be updated. So there's a couple different things going on. First, we're working on a new contract with NCCASA to validate the data so that this data will be even more clear and the definition will be validated. But then also we know that NCCASA, it's a whole process for them to pull county by county data, but we're working it out that they can do this for us, hopefully annually. So it's a work in progress and it will be updated. But when, Bianca, I'm not exactly sure. I'm sorry.
Thank you for that clarification. I'm glad that you said that because I'm not, so I don't lie to you all. Yeah, good. That's good. And I'm glad that hopefully you can work out where it's updated annually so that you all will always have these numbers to look forward to and can track over time. So we'll just keep you all posted on that. But again, having the chunk of data between 2019 and 2023 is useful because you can see general trends that have happened in the past few years in your service area. Okay, so again, the 18,500 tells us that sexual violence survivors are seeking help from emergency rooms in North Carolina. And that reflects both a need and access to emergency care. We don't know if 18,500 is high or low, but it does tell us, it offers insights about patterns over time and that patients are seeking care in the ED across the state. So that might be a potential avenue to reach them or to encourage or to reach them with more resources. The next set of data is about gender identity. And we're seeing this graph here that statewide, the majority of emergency department visits for sexual violence are among female patients compared to male patients. So 89% of the visits were among female patients and 11% were among male patients. And this is consistent with national data on help-seeking behavior. It could be that females are more likely to experience sexual violence or that females are more likely to seek medical care at the emergency department for sexual violence events. Could be that the sexual violence is more severe that they have to go to the ER, or just general females tend to have more health-seeking behaviors compared to men. So this, I think, is useful to compare to your local service area, and you might want to pay attention to the proportion of male patients. So if your service area provides a different percentage that's different from 11% here, that might indicate the need for more inclusive outreach or education or services tailored to male survivors. I should also mention that in this data set, the NCCASA data, gender identity is reported using 4 categories: female, male, unknown, and missing. The NCCASA data does collect gender identity information for transgender individuals through other systems, but this data is sometimes incomplete and not enough transgender people report receiving emergency or being transgender and receiving emergency care, at least in these years. So those numbers are low and are not reflected in this data set. So please keep that in mind, that transgender identities are currently not reflected in this data just by the means of how the data is collected and what's available to us. So the tool isn't perfect, so you'll probably have to match it with other information that you do have in your service area, but it does give you sort of a quick glance about the who is seeking care through emergency rooms for sexual violence.
Bianca?
Yes.
Yeah, I just want to add, for those of you that like play around with it and look at like other counties and stuff too, you'll notice a trend, which I found like really interesting, that there are more males that have like sought treatment than you would think. So I know like a lot of rural areas don't really like focus on like male survivors at all, but it's something to think about whenever you're looking at the data.
Absolutely. Yeah. I mean, even though 11% is much less than 89%, there's still a large chunk, right? A tenth of people who identify as male are seeking care, which is a huge priority population. Thank you for highlighting that, Umar. All righty. What I will mention though about this data, since if you are looking at your, yes, thank you, Sarah. If you are looking at your service area, sometimes when the number of observed events, so meaning the number of ED visits is between 5 and 9, you have to think about the finding. You have to interpret the findings with caution, essentially, because the numbers are so low. You know, it might not be stable, essentially, or as accurate as it could be. And then also, if the number of visits for any group is below 5, it's not reported at all. So if you see a 0, it might not be a true 0, right? It might just be that there are fewer than 10 participants and it's not reported, or fewer than 10 visits for that type of person and it's not reported. And Sarah mentioned in the chat that you love thinking about how the data shows us where our own biases may be showing up too. And that is really important, as well, as Omar pointed out, especially when thinking about gender identity and who is most impacted by sexual violence. It's not always, you know, uniform. It's not always cut and dry about who it is. And this information being updated would definitely help to see over time how that changes and compare to the state as a whole, compare to different service areas. All right. So the next set of information on the dashboard is organized by age group. And we're seeing here, using this graph, that younger people, especially those who are under age 25, account for more emergency department visits related to sexual violence compared to those over age 25. And this graph is useful because it shows rates, and rates are a rate per 100,000 North Carolinians. And it's helpful because you can compare, you want to use rates so that you can compare numbers that account for differences of population size. So regardless of your population size, this number here, this rate can tell you where the burden lies, or who is accounting for emergency room visits the most, sort of on a comparative scale. So according to this data, most of the visits are with 18 to 24-year-olds, so young adults. They have a 79.9 rate. And next is young children, 0 to 4 years old, followed by children and teens, 5 to 17 years old. And these are much higher rates compared to older adults. Now, this, again, you have to interpret this knowing about what, you know, providing context to it. It might just be that older adults aren't seeking out care for sexual violence compared to younger children or young adults. It doesn't necessarily mean that they're experiencing sexual violence less. It's just they're seeking out emergency room visits less than younger children and young adults. And also you have to think about maybe parents are taking children to the emergency room. They have that access piece to it. So the looking at this, just the raw data, you might be inclined to say, okay, 18 to 24-year-olds are experiencing sexual violence the most. And that could be the case. But at least we know that those who are actually going to the emergency rooms for care fall into the young adult age range and fall into the young kid range, unfortunately. And this trend just highlights where your prevention efforts, where your education and services are most urgently needed, probably among youth and young adults in this case. Or if you want to, or this might show that older adults might just need more information or resources or access to health seeking services. And Omar mentioned in the chat that this data may be showing some generational curses being broken on speaking out. I see that, yes. Like I mentioned, with maybe parents or caregivers taking their children to the ER with these high rates, or young adults seeking out services on their own. Yeah, you see that could be a pattern of generational curses being broken. I love that. The 0 to 4 numbers are concerning. Did I interrupt somebody? Okay. Yes, the children 0 to 4 years is concerning, but again, this doesn't necessarily mean that they're experiencing sexual violence the most, but clearly they are, and they are seeking out emergency room care for that. So that's just another tool or information that you have to know where folks are so you can meet them. Deanna says some communities, child advocacy centers do not respond 24 hours a day. So the ER is where parents take them regardless of whether the assault was acute or non-acute. That is a great point to say. Yeah, so maybe ER is a place of service that they go to immediately. And maybe younger or older adults might wait to the next day or seek out services at another place that's less public maybe, or that they're familiar with, right? So again, this tool, this dashboard is one useful tool in your complete arsenal, just about showing what your service area looks like and where to reach folks and who you could reach at these places. Yes, thank you, Sarah, for that validation. We know that sexual violence happens to people 0 to 4 years old, but this could be a data limitation showing up. I'd be curious to see if these numbers stay the same after the data is validated, right? And validated, yes, checking for its accuracy, and making sure that it's depicting what we want it to depict. And that's why that definition of sexual violence is so key. That's why they're testing it. We want to get your feedback on it so that we can continue to tweak that so it could be the most accurate. A lot to do with the OBGYNs based on what we have been told by providers. A lot of older adults get care with their OBGYNs based on,
Yeah, sorry. I was trying to
Thank you,
type and
Denise.
it was not working for you. So what we've been told, and again, this is just subjective, word of mouth from OBGYNs, is that a lot of older adults actually go seek care with their OBGYN, whether it's immediately after or it's at their next annual visit, or pap smear is when they are disclosing that information.
Great. Thank you for that clarification. Yeah. And so that's really interesting. Again, that's providing context to the numbers you're seeing. And so if you want to reach young adults or young people for sexual violence prevention, they're showing up in the ERs. And so that's a place to see that. If you want to reach older adults, maybe the data is showing that they're not showing up in the ERs. So you have to reach them in other ways. Thank you for that clarification. And all of this, I love this discussion because it's bringing up meaning behind the data. And this is things that you can communicate, especially with folks who are saying, oh, we got to do something about those young adults who are experiencing sexual violence. If they just want to use it in a harmful way, you can say, well, this is what the data really means, that this is helping us identify where we can reach them. Okay, I'm going to move on. In the last section, sorry. Okay, Sarah. Oh yeah, the validation was checking the accuracy of the surveillance definitions used. Yes, exactly. So the last piece of information that the dashboard provides you for your service area is the emergency room visits related to sexual violence by race and ethnicity. And you can see here across North Carolina in between 2019 and 2023 that the rate of ED visits related to sexual violence was the highest among Black individuals and Native North Carolinians. And so again, these are rates, not raw numbers, but it's helpful to see it in a rate because it accounts for the size of the population group. It puts some comparable planes so that you can see Black people have higher rates, or not necessarily that they're disproportionately affected by sexual violence, but they are showing up in emergency rooms for sexual violence at a higher rate compared to other races and ethnicities. So this trend can still point to possible disparities in access to other care settings, but it also can point to things like community trust or mistrust rather, in healthcare systems. We know that certain races have been impacted by healthcare systems in different ways. And so, maybe they're not seeking out care, or that's the only access that they have available to, for the reasons that we've been describing before. But these insights, again, can help you frame conversations around health equity, around your community outreach, and even your funding advocacy to see who needs to be served in your communities. Like Deanna mentioned in the chat, it would be interesting to compare the race data for showing up at the ER to census data for service area. That would be great. And that's why we're using the rates here, because it will tell you, it will give you that comparison regardless of what the size of the population is. But keeping that in mind is is very concerning, right? Especially if Black people and Native American Indian and Native individuals make up less, a small portion of your community, but they have higher rates of at least going to the emergency room for sexual violence. So again, this can help you frame conversations around health equity. It can help you be specific with different communities in your outreach. And it can help you with advocating for these individuals.
Bianca,
Bianca,
if I could just, sorry,
Go ahead.
go ahead, Omar.
Go, Deanna. I was just going to make sure Nutella, Miss Faison, meant to go off mute.
Okay. So I think another thing, and this is something we have continued to lift up at NCCASA for over the past 10 years plus, which is asking rape crisis centers to look at their own race and ethnicity demographic and compare that service number to these ER visits. Because what we know from the Sexual Assault Demonstration Initiative is that underserved and marginalized communities continue to seek services in other community pockets outside of the mainstream rape crisis centers. And so I would encourage folks to also look at it through that lens, to think about your own practices and how you can show up for those communities, since they are overwhelmingly coming to the hospital for support.
Great, thank you.
Yeah, I want to echo what Deanna says. That is true, especially in rural communities with people caring what others think. I.e., a person in Whiteville may go to Wilmington for treatment and be referred to Coastal when Families First is in their own backyard, and a lot of people may not know about them because they don't want to know, or because of the guilt and shame of seeking help in your own communities. So yeah, that was a very good point. And before we move on, I wanted to make sure, Miss Faison, they came off mute. I muted you because I heard background noise. I wanted to make sure they didn't have a question. Okay, must have been my mistake. Moving along.
Thank you. And I really appreciate y'all providing that context. So data or information, right, is information that helps tell you something about your programming, about your services, and your outreach. And it's great to combine multiple sources to get a complete entire, big picture look at what your service area looks like. So yes, combining this dashboard data of emergency visits with your service area and who you're serving, and even the census of who makes up your service area, comparing all of those things and seeing where there are discrepancies or where there are certain communities that you could prioritize more, right? Or seek out more, or just learn from more, because they are showing up in emergency rooms in your area. All right, so that is a great segue into the next part of the training, which is the large group discussion. And I'm being aware of the time, so we're going to move this along. Can y'all see my screen? Okay. And thank you, Deanna. Yes, if you have questions about comparing your reported data to CFW,
Yeah, so what we do at NCCASA, and we've done this for probably even before COVID, we take a look at the information that agencies submit in their statewide report to the Council for Women, which is a funder, and we compare it to the census data to show the differences in you know, who's showing up in their organizations compared to who's living in their communities. So we have this information if you ever want it. We use it for internal use, but if you'd like to see it, just email me and I'm happy to provide you with that information.
Awesome. Yeah. Piecing different things, information together and tell a full story. NCCASA is here clearly for, for you to use, to tap into. And then also not if you just want access to that information, but if you want help practice interpreting the dashboard or the comparison with the census data or CFW data, like the actual interpretation of what that means for your service area and for your service provision. That's, part of TA that NCCASA provides, and definitely tap into it. Okay, so now I want to hear from you all. I've walked through the dashboard, and it again provides us 4 points of number of visits by gender identity, by age group, and by race and ethnicity group. Those 4 pieces of data could tell you something about your program, right? But I want to hear from you all about how you plan to use this type of information to support survivors. And this will help us also be able to provide more targeted TA or information or resources to you to help you use not only the NC Detect data, but the dashboard and also what to do afterwards, which we'll talk about in a second. So I had planned to do this group discussion for like 30 minutes, but it's not going to take that long because we have more stuff to talk about and I want to get to it. So just want to go through, spend the next, 10 minutes or so reviewing these questions. And I'll go through each of these one by one and try to move us along to get through them all. Feel free to come off mute. Feel free to just talk in the chat if you choose to. But we really just want to hear from you so that we could better provide more targeted resources and also to help tweak that definition of sexual violence and provide information for the surveillance folks, to the NC Detect folks to get information. So thank you, Raina. This is a great point. Like I mentioned before, if there's any feedback on the data dashboard, if there's something that is missing or doesn't look quite right, we will make adjustments. There is a form to fill out. I'll share the link at the end, but you can also email prevention@nccasa.org. And so we'll have a sort of running email list of changes to make to that dashboard and we'll update it.
Yes, I was gonna.
Okay, good. Okay, good. Yeah, I said it right. All right, we definitely want to make sure we get all of the counties that you all serve. And I know that, this was, if there are new organizations or if y'all are doing new things, we want to update that. So thank you for that. Okay, so again, come off mute or in the chat, but I want to hear from you. First, how could you use this data to improve support for survivors and to advocate for change? In what ways would you use this data? Teresa, go ahead.
So when we were looking at the graph about the percentage of men reporting versus the women, I just wanted to mention that our agency did a name change just because of that reason, so that the community, our men in the community can feel included. And the tools, the data that I can use with this, when we go and do like networking fairs and such, we can also have something to mention, pamphlet or flyers to show that our men are included.
Love that. Yes. And yeah, at the very least, this tells you who is in your community, right? And I love that the agency changed the mission to align with males and to be representative and to show that you all are a resource. Yes, using this information on a dashboard can help do that. And I like that you mentioned using it at network fairs and in pamphlets. After this, I'll show you a visual about how to present this information, but I think that that's useful, quick way to just show the need for the work that you're doing with anybody who comes by. So thank you for sharing that.
You're welcome.
Bianca, Deanna wrote in the chat that we pulled per counties from the Rape Crisis Center. So make sure your administrator is updating your stuff in Coalition Manager. So yeah, we typically don't do that updating. They can go in and add whatever counties, and as well as adding those of you that are members, adding staff and stuff. So that is good information to know. Thank you for that, Deanna. And
Yes.
Emily, go
Oh,
ahead.
sorry, Omar. I was also gonna say that if you don't know who your administrator is because of staff turnover, please get in touch with me. Happy to help you with that. Another caveat is if you are recognized by the state as an agency that is serving that county. So there are some counties in North Carolina that do not have an active rape crisis center serving them, and multiple agencies are doing that in lieu of someone serving as the main pass-through or organization for the state level funding. So if you have questions, just reach out to me and I'm happy to figure that out. So we might have multiple agencies who are serving a particular county because there's no one there and they're the surrounding agencies, even if they don't receive funding.
Deanna is the resource for sure. So when in doubt, email her or prevention@nccasa.org. Okay.
And
Go ahead.
Emily wrote grant writing, Bianca, and I'll let you.
Great, thank you. Grant writing for sure. You always have to demonstrate the need for anybody providing resources. And this is it's a good data point to include, especially because it highlights sort of cross-sector work. I'm not sure how many of y'all are health providers, but seems like a lot of you are community-based organizations or work with law enforcement or work with schools or rape crisis centers. So having connections to the healthcare system or to hospitals especially is important. And so that identifies, say you're seeking out funding for that type of work, that can help identify sort of that cross-sector collaboration that is potential. Any other ways that you could use this data to improve your support for survivors or to advocate for change in your community? I love that. To make a case for hospitals to support having more SANEs, which are the sexual assault nurses, right, on staff. Yes, again, that's that cross-sector collaboration potential that this data demonstrates. So you can see a need for it in your community of where to, to have your outreach strategies and services. Any more before we move on?
Maybe when doing outreach to have different agencies join the coalition or task force or whatever to support why we may need certain organizations to be a part of the coalition.
Absolutely. Yeah. And a lot of you who are on the RPE program already know about the task force and coalition building. Absolutely is helpful for recruitment because it demonstrates, in an easy to sort of digest fashion where the needs are. And you can target specific organizations to help join the cause. So it's great. It's a great recruitment tool. Sarah mentions to enhance relationships with hospitals, possibly if there are more ED visits than the Rape Crisis Center is receiving. Maybe we want to advocate that our ED call the Rape Crisis Centers in more frequently. Absolutely, absolutely. So relationship coalition building, and it tells you in particularly where folks are receiving services. So that could be that they're going to the ER because they don't know that other resources are available in their communities, or that's where they feel most comfortable. It just tells you something more about where to reach them. To increase buy-in and participation in hospital accompaniment programs. Absolutely, yes. It improves your agency services with the hospital accompaniment programs. Absolutely. Community buy-in, yes. Great. All right, I'm going to move us along to the next question. What tools or visuals do you think would help you do that? Teresa mentioned using this information on pamphlets for a networking fair, community fair. What other ways what visuals could you use to help you use this data? Infographics, yes. And infographics are, usually 1 to 2 pages that show the cause that you're working towards, information that supports that cause, and like a call to action at the end, what to do about it. It tells the results of your programming. Any other tools or visuals that you all wouldn't possibly use this information in? What about in any presentations that you have, and who would those presentations be with?
All right, I just wanted to clarify, I thought originally we were saying we couldn't use this data for presentations, but can we? Or
Yes, that's a great point. Thank you, Vivian. So you can use this data, and I'll show you how to use it. There's a large spider, sorry. It's outside, it's great. Don't report on this as definitive numbers saying, in this period of time, 600 people showed up at the ED for sexual violence prevention. Just show trends. So you can show the graphs, which show the rates and things like that, which are what I mean by trends. Just not use it as as definitive numbers, as this is what's taking place, and always have the caveat, and there's language on the one pager I'll provide. Always have a caveat about how this data is still being tested, it's not perfect, and so forth. Thank you for that clarification.
well, then in that case, then maybe in presentations, where you're trying, I'm working with like high school groups, so I don't know yet, but like maybe sharing the data so that they can determine what are some protective factors, or what are some risk factors, and then, gear their projects or their advocacy around that, like using this data as a brainstorming on how we can prevent it.
That's great. Yeah, use that strategy in the people you work with, the programs you're working with, in your actual agencies, really as a tool. It's a tool to improve your strategies, right? As a brainstorming tool. I love that. And then the folks that you're working with can even provide more context into why you're seeing certain rates and certain numbers. All right, and number 3, is there anything that would help you make use of this data more effectively? Like, think about things like trainings or any other help with data interpretation or support that you need to use to make better use of this data.
Has it been mentioned anywhere if a collaborative meeting with law enforcement that could go hand in hand with showing, like the need in the community? I don't know if my agency has ever done that. I don't recall ever seeing a collaborative meeting with law enforcement, but I think that would be a wonderful idea.
Yeah, I'm hearing that it would be useful for communicating, not only communicating the need in your communities, but to get buy-in, especially if you're building relationships with different agencies or organizations across sectors. Thank you, Teresa. Yeah, okay, Holly, I like to be able to see the numbers per year. And that's helpful feedback. Right now, like I mentioned before, they're combined for 5 years because the data is still being tweaked, but we want to be able to see general trends. But I do agree, especially if you want to compare to the coming data in next year, well, 2024, and then previous next years after that, you want to be able to see it across time to see how that's changing. I do want to mention that, again, context is always important. If you even see numbers of ED visits going up or down, it can tell you different things. Going down may not necessarily be a positive thing. Maybe it means that folks are not seeking out care for sexual violence. Going up could mean that could be a positive thing, that folks are actually seeking care and not, staying at home after these types of events. So again, always having that context matters, always having the story behind it, and using this as one tool combined with other information that can tell you something about your service area. I'm going to move on. And the last question is, are there any other types of data or any other indicators that you wish were included? Holly's saying you want to see numbers per year. That's very helpful, and I'm sure others could benefit from that. Any other types of data or information you would want to see? Deanna mentioned having the census numbers by population next to it would be helpful to make context. Anything else? The age range is less than right. Yeah, they are in pretty wide groups, and that's usually because of numbers. Again, the fewer the amount of visits, the less likely it's going to be reported in the dashboard, because for privacy concerns, if it's less than 10 visits for that population, it's not reported or not at least shared with us. But yes, for especially that large age range for 5 through 17, it would be cool to see the differences. Languages spoken, that's a good one. Yeah, absolutely. And that has the impact on, health seeking behaviors. If folks don't feel like they will, be included, they might not seek out emergency rooms for care. Or if they know that there is a translator there perhaps they might seek it out for care. So languages spoken would be great. Any other things, any other data points about the people who are visiting emergency departments for sexual violence that would be effective? Repeat visits, yeah. That's great. Yeah. Unfortunately, we only know the number of visits, not who is there, but I think that eventually, or with enough people, we will be able to tell that. Housing, language disability, yes. And if they overlap with SV visits, that helps us tell, social determinants of health in particular. Kits done, reported versus anonymous, medical services only, yes. So I'm hearing all of these are to provide more context to the people who are visiting the emergency room departments, and that will help you improve your outreach strategies, right? Or tell you something about where to reach those populations. All right. Thank you all for your participation. This is really helpful. This is being recorded, great. So we're going to try to capture some of these things for you all, or at least help provide data or ways to seek out this information to match with the dashboard data. In the last few minutes, I want to talk about creating visuals and tools. And I'm just going to go through this kind of quickly, but please interrupt me if you have any questions. This is, it's kind of blurry now. I was going to navigate it to the PowerPoint, but I think you can pretty much see it, what it looks like. This is a one-pager that summarizes the sexual assault emergency room data for the entire state. And you can download this one-pager from the coalition manager. It's a PowerPoint form, so you can make changes to it and actually take those graphs that were in the data dashboard and copy and paste them onto this PowerPoint visual. Use this, don't reinvent the wheel, if you don't have to. It's a good, like Teresa was saying, wanting handouts, it's a good, just quick handout to hand over to somebody to tell about what you're doing and why they should care. And what this is showing is at the top, it tells you the big picture story. Sexual violence survivors are seeking help from emergency rooms in North Carolina. That's the big picture story, the so what of the data that's going to be presented. And then we present 3 different charts that tell the rest of the story. You know, you got who is seeking it in terms of gender identity, more female patients. You're having these sort of call out descriptions of what the graph is telling you. Instead of having a title of the graph, you're just telling the viewer what the graph says. So young people visited North Carolina emergency rooms more than people over age 25. And then same for race and ethnicity. And this graph is by gender and race and ethnicity, which is pretty cool. And if you would like to see your data like that for a visual, we can help you create that graph as well. At the bottom here in the yellow box, there's a call to action. So you want to give people something to do once they've gone through your entire document. What do I do now? I know what you're talking about. I know the data. What do I do now? Well, the call to action in this case is if you want to work with us to support survivors and change systems, please contact this information. You can also have, you know, a link or QR code to your website or to your services. Always have your logo here, but you want to give somebody something else to do after they review your information. And so this is a nice, useful handout if you're trying to get buy-in or people to join your task force coalition, giving it to them straight up and easy. At the bottom, it has the sort of caveat for the definition of sexual violence that says that this is not a complete or the accuracy is still being assessed. Please always include that, that description if you are sharing the data from the graphs. Like Vivian said, and you can share or asked about, you can share the information from the graphs, but again, it tells sort of the big picture. It doesn't give definitive numbers. All right. So when you're choosing a tool to create, you want to ask yourself these questions. Look at the data dashboard for your area. What stories are the data telling you? And we've gone through all of the different stories that you're seeing. I keep bringing up Teresa, sorry, because you spoke up, but your example of, you know, identifying with males and reaching males was an important data point that emerged for you. So looking at the big dashboard for your area, what stories is it telling you? Then you also want to consider what other information or stories you can add in there. I've been mentioning this data is imperfect, it's incomplete, and it's just one picture, it's one part of the story, right? So you want to add in other information or quotes if you have pictures, well, maybe not pictures, but anything from survivors or advocates that are involved, you might want to add that information there. So the hospital accompaniment data that was mentioned before, client feedback or survey data. Consider who your audience is and how it will be delivered to them. How comfortable are they with graphs? Maybe only include one of the graphs. That's really the highlight as compared to all 3. Considering the software you use, we have the dashboards on Excel, we have the visuals on PowerPoint, but there can be other software that you will use. And if you want help with that, please reach out. And my tip for everything, I do data visualizations constantly. I always grab a pen and paper and sketch it out first, just to see what it looks like before I work on creating it digitally. It just saves so much time to see what it looks like. And you can use this information in a one-pager, in a handout, PowerPoint, a report. Okay. Oh gosh, I just want to say one more thing before I close. This is really important, and how we talk about health disparities with this data. So we want to be careful to not unintentionally reinforce stereotypes and reinforce oppressive messages. You want to reflect on what you're really trying to say first. And if this data, this information is sharing or helping you do that, right? Don't want to continue to perpetuate negative stereotypes by saying a certain group of people are, you know, the ones experiencing sexual violence, or they're not seeking out care, whatever is negative. Make sure that your messaging behind the data does not reinforce that. And it just allows, to do this, you just have to be extra reflective before you present it, and thinking about to make sure that it's not reinforcing these negative stereotypes and is sharing what you want to actually share. And then it's helpful to name why the disparity exists if you share it, right? If you see that Black people are accessing emergency room visits for sexual violence more than other groups, well, why is that? Are there disparities in access in general, community mistrust in the healthcare system, things like that, or differences in health-seeking behavior? I always want to provide that context to help us not reinforce those negativities. Okay. So I'm done. I didn't leave a lot of time for questions, but I will stay on a little bit longer if you do have a question. And as always, please ask questions. I want to highlight the feedback for the data dashboard and one-pager template that is on the Coalition Manager, that form that you can always fill out at any time you're using a dashboard, especially if there's data missing that you would like to see. And I'm going to leave with you all putting in the chat now how you're feeling about using the sexual assault ER data.
And
Please.
before you go, since we have 1 minute, in case you're in a rush, please do not forget to fill out this survey. It's very important. I put it in the chat.
Thank you, Omar. You always want to evaluate your evaluation. So definitely fill out the training evaluation survey. The first 2 questions on the survey talk about changes in knowledge and skills for you to conduct your services. That the service we're talking about in this case is using this ER data to promote change. So just keep that in mind when you're answering the first 2 questions on the evaluation. And thank you for your all's participation. If you want to leave and put a number in the chat about the image that you're feeling, feel free to do that, and I will hang around.
Yeah, we'll be hanging around still. I know some of you have to go. This was a great training. Thank you, Bianca. I don't always enjoy data. I love putting it into action though, but I enjoy learning about the tool more in depth.
Contact Deanna for any questions or prevention at NCCASA.org. So the survey, Emily, is both in Spanish and English. Each question has the Spanish and English translation. So just look at the latter part of the question for the English. Oh, great, Deja. You went from 2 to 4. I love to hear that. Love it. From a tornado to a rainbow. Thank you all.
I love that too. Yeah, same. I'm with you, Deja.
Alrighty. Thank y'all.
Yes.
Good afternoon.
Londa, my girl. Good to see you.
All right. Yay.
Thank you all. And again, if you guys want to put any of this data into action, get up with us and we'll help you. So
absolutely. And have a good afternoon. And I guess Omar, you can stop, or Emily, or